It's really a pleasure and honor for me to be part of this webinar. It's amazing to be able to do this from halfway across the globe. Right now, it's just 3 minutes past midnight here in Maryland, and it's very amusing and amazing to be able to do this. I'd like to thank, before I proceed, Dr. Marisha Recto for inviting me to be part of this program. She gave me the assignment of talking about allergic rhinitis and its link to asthma. And what I'm going to do is to try to propose to you that this is actually one airway and one disease, and provide data and information that would support that notion or hypothesis. So there's going to be the outline for my talk. Initially, I'm going to talk about the prevalence of these conditions, basically demonstrating that there's a lot of overlap between allergic rhinitis as well as asthma, both here in the US as well as in the Philippines. And I'm going to spend some time discussing pathophysiology with the clear notion that this will be the basis for understanding patient care or treatment. So regarding prevalence of asthma, you can see here that in the US, the prevalence is about 7.4%, and given the population of the US as of 2013, that amounts to about 23.6 million of individuals in the US who have asthma. In the Philippines, the prevalence is quite similar. This is based on studies published by Dr. Barona and others, published in the Philippine Journal of Internal Medicine in 2014. You can see that the prevalence of asthma is about 8.7%, and given the population of the Philippines, that amounts to about 8.6 million. So here you can see that there's a huge number of individuals who are affected by asthma, both in the US as well as in the Philippines. If you look at the prevalence of rhinitis, in the US, it's about 17.7% based on studies looking at surveys wherein they asked responders whether or not they have had nasal symptoms for at least 30 days out of a year. And based on that study, close to 18% of the population here in the US have rhinitis. In the Philippines, this is based on studies published by Dr. Abong and others in the Asia-Pacific Allergy Journal in 2012. The prevalence is about 20%, and that amounts to about 19.7 million affected in the Philippines. So here you can see that the prevalence is quite high. One detail that I want to point out is the fact that this includes the general population. Now, if there is a relationship between rhinitis and asthma, the question now would be, what would be the prevalence of rhinitis among asthmatics? And one can hypothesize that the prevalence probably would be higher. And that question was answered by Jenna Capsali at Hopkins several years ago. She was one of our fellows. And in a simple study, just looking at surveys, she demonstrated that among asthmatics, teenagers with asthma, as well as adult asthmatics, you can see that the prevalence of rhinitis is quite high, 88.8% among teenagers with asthma, and about 94% among adult asthmatics. So going back to the point I made earlier, in the general population, the prevalence is about 20%, so about 1 out of 5 people in the general population would have rhinitis. But if you look at those with asthma in particular, you can see that up to 9 out of 10 of asthmatics would also have rhinitis. So I made this slide to drive home that point. You can see that I like to play with graphic arts. And the point I'm making here is that if you have somebody presenting to your office or clinic or the hospital with asthma, look closely, because more than 9 times out of 10, you can also see rhinitis. And what is important about that? Well, a number of studies have shown that rhinitis can have an impact on asthma. And this was demonstrated, for example, by a study published by Hughes and others several years ago, wherein they compared patients with asthma who either had severe rhinitis or those who had either no rhinitis or just mild rhinitis. And what you can see here is that those Asthmatics who have severe rhinitis have more frequent asthma exacerbations, more frequent nocturnal symptoms, and more related work loss. In other words, the more severe the rhinitis is, the more severe the asthma tends to be. In contrast, if you treat rhinitis, you're going to improve not just the nasal symptoms, but you're also going to improve asthma as well. And this was a study published several years ago at the Mayo Clinic, wherein they compared the effect of placebo nasal spray versus intranasal steroids, flunisolide and beclomethasone at that time. And in this study, they demonstrated that the treatment with intranasal steroids compared to placebo produced significant improvement in rhinitis symptoms, which is to be expected. What was interesting is that if they looked at the asthma symptom scores, they also showed improvement. So as a ragweed pollen count went up during the fall season, you can see that those treated with placebo nasal sprays had an increase in their asthma symptom scores. In contrast, those who were treated for their rhinitis either with intranasal flunisolide or intranasal beclomethasone sprays, you can see that there was no exacerbation of their asthma. Again, this clearly demonstrated the treatment of rhinitis improves not just nasal symptoms, but asthma symptoms as well. This is another study published more recently by Crystal Peters and others, looking at different outcomes. And you can see here those asthmatics whose rhinitis was treated had less frequent trips to the emergency department and had decreased hospitalization rates as well. So again, driving home the point that treatment of rhinitis also improves asthma outcomes. So that's related to prevalence. What about pathophysiology? In the next several slides, I'm going to show a number of data, as a lot of them I generated back when I was a fellow at Johns Hopkins several years ago. When I was putting together these slides, I was thinking twice as to whether or not I should even talk about pathophysiology. And I decided that this is really critical, and this is one take-home message actually from this talk. You have to understand the underlying pathophysiology of any condition, whether or not you're talking about allergic rhinitis or asthma or hypertension or kidney disease. If you do not understand the underlying mechanisms of the disease, you will be clueless as to where the targets are. So hopefully, after this short webinar, you will have a good understanding of where the targets are in relation to allergic rhinitis as well as asthma. This is a busy slide. This is some figures that I made for this book, Principles of Ambulatory Medicine, several years ago. But what I want to point out at this point is the fact that you can more or less divide the disease process in two stages. The first stage being allergic sensitization. And this happens in a genetically predisposed individual, and genetics is clearly a major part of allergic rhinitis and asthma, and there are a number of studies that demonstrated that. So if you have somebody who has a higher risk or probability of developing allergic disease or asthma, the first step is the development of sensitization, which happens upon exposure to relevant air allergens. What happens is that these allergens are absorbed. The allergens are proteins. They are low molecular weight, so they can float in the air. They can travel for hundreds of miles if you're talking about pollen, for example. And they're highly water soluble, so you can imagine that they can get inhaled into the respiratory tract and they get absorbed, and they are presented by the antigen presenting cells like Langerhans cells, dendritic cells, to T lymphocytes. That's a cartoon, but it will be much more cooler if you're able to watch the actual APCs or antigen presenting cells interacting closely with a T cell. It looks like it's eating a T cell, but it's not. So what's the effect of that interaction? Well, the T cell becomes activated and they start producing what's called cytokines, interleukins such as interleukin 4 and interleukin 13, which then activates B cells to proliferate and mature into plasma cells and then start producing IgE antibodies. So once you have IgE antibodies being produced by the plasma cells, you are, by definition, sensitized. Clinically, how do we know whether or not IgE antibodies are present? We can do allergy testing, and this is one form of doing allergy skin testing wherein the relevant allergens are introduced superficially into the skin, and you can see within 20 minutes or so you can develop this reaction, and I'm going to demonstrate in the next several slides how this develops. So clinically what you can measure would be the size of the wheal or the swelling as well as the erythema or redness around it. And this is something that we do on a regular basis to answer the question as to whether or not allergen sensitivity is playing any role with regards to a patient's condition. So once you have IgE antibodies that we can measure by testing, then the next stage will be the development of an allergic reaction. So if you are allergic, say, to cat allergens, that means that you have IgE or immunoglobulin E antibodies against cat allergens. And when you're exposed again to those cat allergens, what happens is that you have cross-linking of the high affinity receptors that bind to the IgE antibodies, and that will eventually result in the release of different mediators that I'm going to demonstrate in the next several slides. So again, the first stage of allergic disease will be the development of sensitization, resulting in the release of or production and release of IgE antibodies. And then the second stage will be the allergic reaction, which can happen upon exposure to the same relevant allergen down the road, and that can result in release of mediators that would then be responsible for the development of the different signs and symptoms associated with allergic rhinitis as well as with asthma. What I'm going to talk about now is the parallelisms or similarities or overlap between nasal and lung histopathology as well as pathophysiology. I'm going to talk about what happens in the nose as well as the lungs in relation to inflammation, what happens in relation to what's called the early as well as late phase responses, and then I'm going to talk about hyperresponsiveness and how this can be demonstrated in both the nasal and lung areas of the respiratory tract. So regarding the anatomy and the histology, there are similarities and differences between the nose and the lungs. You have epithelium that is present in both the nasal and bronchial airways. You have glands and the nerves. What's different is that in the nose you have venous sinusoids that when engorged can result in congestion. In the lower respiratory tract, in asthma, you have smooth muscle that can constrict, resulting in narrowing of the airways and difficulty in breathing. So again, in the nose, you can have nasal congestion because of edema. In contrast with asthma, you have constriction of the smooth muscle, resulting in narrowing of the airways and breathlessness. Regarding pathophysiology, what I'm going to show is how we can actually demonstrate what happens in both the nasal and the pulmonary passages upon exposure to relevant allergens. So in the lungs, you can do this, and I'm going to share some results from other investigators that looked at what happens as part of an allergic reaction in the bronchial airways upon challenge with allergens. So here, what they do is they introduce the relevant allergens directly into the bronchi, and then they collect samples or bronchial lavages that they can analyze in terms of the different levels of mediators as well as the types of cells that are released into the airways upon exposure to allergens. What I've done during my fellowship several years ago is take advantage of the fact that the nose is much more accessible, as you can see here. So what I did during fellowship as part of some of the studies that I performed at Hopkins was something similar to bronchial challenges and bronchial lavages, but involving the nasal passages, which is much more expedient, as you can imagine. So the nasal challenges involves the delivery of relevant allergens into the nose, depending on what you're allergic to. If you're allergic to ragweed or grass pollen allergens, then that's what you're going to be challenged with. And then we collected nasal lavage samples. So what I did then was I instilled the lactate bringer solution into the nasal passages, and they would expel it into collecting bases like this. And then that's what I analyzed in terms of the different mediators as well as cells that are released as part of the allergic response. When I described it to some people, they would ask me, is that gross and disgusting? I would just tell them, of course it's not. I know it sounds cheesy, but actually it's not. So this is the protocol that I employed, wherein I delivered nasal challenges, including either ragweed or grass pollen extract at increasing doses using the technique that I described in the previous slides. And then we collected nasal lavage fluid samples before and then several time points up to 12 hours after challenge. You can imagine this was a very long study, and we had to stay in the lab past midnight to complete the studies. So I guess in retrospect that was somehow in preparation for the session that I'm doing now. Again, staying up at 12 midnight doing this, but this is something that I enjoy in the same way that I really enjoyed doing those studies back then, more than 15 years ago. Aside from the nasal lavage fluid samples, we also collected symptom scores using visual analog scales. And this is what we found. You can see here that the allergen challenge resulted in the release of histamine. You can see a good dose response curve here. And this happens within 10 minutes of exposure. So you can imagine if you are exposed to something that you are already allergic to, meaning you already have IgE antibodies against those allergens, within minutes of exposure you can have this response. That's in the nose. What about in the lungs? What happens? This is based on studies by Georgiou and others from National Jewish in Denver. They did bronchial challenges and collection of bronchial lavage fluid samples. And you can see here there is a release of histamine following allergen bronchial challenge compared to saline bronchial challenge. So again, you can see here that what happens in the nose regarding release of histamine also happens in the lungs with allergen exposure. What are leukotriene levels? We also measured levels of leukotrienes, and similar to what happens with histamine, you can see a good dose-dependent increase in levels of leukotrienes in nasal lavage fluid samples within 10 minutes of allergen exposure. What about in the lungs? Sal Wenzel and others in Denver demonstrated a similar increase in levels of leukotrienes in bronchial lavage fluid following bronchial challenge. As you can see here, within 5 minutes of allergen bronchial challenge, there is a significant increase in levels of leukotrienes. What about cells? There are different allergic inflammatory cells, including eosinophils. So eosinophils are found in peripheral blood, and they can get recruited to sites of allergic inflammation. Here in nasal lavage fluid, you can see an increase in levels of eosinophils, not immediately, but you can see here 9 to 12 hours after allergen nasal challenge, there is a significant increase in levels of eosinophils. In the lungs, you see something similar. Compared to saline bronchial challenge, there is a significant increase in levels of eosinophils in bronchial lavage fluid 48 hours after bronchial allergen challenge. So regarding inflammation, and that is release of mediators as well as the recruitment of allergic inflammatory cells, you can see similarities between what happens in allergic rhinitis as well as in asthma. What about the early and late phase response? This is what happens in terms of nasal symptoms following nasal allergen challenge in somebody who is allergic, say, to grass or ragweed pollen extract, and they're exposed to those relevant allergens. You can see here that within minutes of exposure, you have the development of nasal congestion. And other symptoms, as you can imagine, included rhinorrhea, postnasal drip, sneezing, as well as pruritus or itching. What you can see here is that several hours later, without further exposure, there was going to be a significant reduction in symptoms. But in about half of patients, and not all of them, but in at least half of them, you have what's called a late phase response, wherein there is, again, the development of symptoms. This concept of early as well as late phase responses to allergen exposure is something important to understand and remember, especially if you're dealing with somebody having a life-threatening allergic reaction or anaphylaxis. You can treat them, for example, in the emergency department with epinephrine if you have to, but you need to watch them closely because they can bounce back, but after several hours they can crash again because of this so-called late phase response. Clinically, what you can do to reduce the probability of the development of the late phase response is to provide steroids in the ER. If you have to give somebody with epinephrine, you want to give them IV steroids as well, like Solomedrol, for example, and give them, or another option will be oral prednisone or methylprednisolone, again with the understanding that they can have the development of late phase response, and giving them steroids will not have an effect on the immediate phase of the allergic response, but can reduce the probability that the patient will crash several hours after treatment. In the lungs, you can see the same phenomenon, early and late phase response. Here, following bronchial allergen challenge, you can see a significant drop in FEV1. This reflects the development of bronchoconstriction within minutes of allergen exposure. And you can see here, within 2 hours or so, it normalizes. But again, about half of have the late phase response, where you can have bronchoconstriction again. So this is a reminder that if you're treating somebody with an acute allergic reaction, you have to watch out for the possibility of the late phase response. So again, the point I'm making here is that what happens is in the nose regarding the early and late phase responses also happen in the lungs. What about hyperresponsiveness? So the cardinal features of allergic rhinitis as well as asthma would be inflammation, number one. The second will be hyperresponsiveness or hyperreactivity. And you can see here the demonstration of that phenomenon of hyperresponsiveness or increased reactivity in a study that I published several years ago, wherein we provided histamine nasal challenges among healthy volunteers versus those with ongoing allergic rhinitis. And as you can see, related to the number of sneezes, those even healthy subjects would sneeze with exposure to histamine. Histamine is something that can cause nerve activation, and it can result in itching or pruritus as well as sneezing. So sneezing is a normal reflex, but you can see, as you can see here, if you have allergic inflammation going on, sneezing, which is a normal reflex, becomes abnormally exaggerated. You can see here among those with allergic rhinitis, increasing doses of histamine resulted in higher probability of sneezing. If you look at the magnitude of the response, you can see here that the total number of sneezes is also abnormally exaggerated. So if you are exposed to histamine, you may sneeze maybe once or twice, but if you have allergic inflammation going on that's not controlled, that becomes abnormally exaggerated, and instead of sneezing once or twice, which is a normal reflex, you may end up sneezing 5, 6, or up to a dozen times. So this is a demonstration of what hyperresponsiveness is in the setting of allergic rhinitis. In asthma, you can imagine the result. This study compared the effect of histamine bronchial challenges among healthy volunteers versus those with asthma. And you can see that if you have asthma and you inhale histamine, there's going to be a drop in your FEV1. So this is what is called hyperresponsiveness or hyperreactivity. Clinically, what is typically used is methacholine. Not a lot of centers do that. But if you have somebody with symptoms suggesting asthma, but it's not absolutely clear whether or not they have this condition, and it has to be established whether or not they have asthma because of employment reasons. For example, if you want to apply to join the fire department, this may be a requirement, or if you have to join the military and you want to rule out asthma, methacholine bronchoprovocation is a test that can be done. So all asthmatics almost always would have response to methacholine, which is a spasmogen. It will cause a reduction in FEV1 if you have asthma. So asthma, again, is manifested by bronchial hyperresponsiveness, and methacholine bronchoprovocation test has very good predictive value regarding that. This summarizes what you see in rhinitis and asthma. You have infiltration of the cells, including eosinophils, basophils, mast cells, and you have mediator release. You have the early and late phase responses, and then you have hyperresponsiveness or hyperreactivity in both the nose and the lung. So the next couple of slides, I'm just going to drive home that point. If you have the lung and you have the nose, you can see that the nose is actually a reflection of the lung, meaning what happens in the lung also happens in the nose, and the nose just happens to be more accessible, and that's something that is going to be important to remember, because rhinitis, as I'm discussing now, is significantly associated with asthma. These couple of slides will summarize the pathophysiology. So again, if you have allergen sensitivity, you have IgE antibodies specific to those allergens. If you get exposed to the same allergens, you'll have cross-linking or bridging of those IgE antibodies linked to high-affinity receptors on the surface of mast cells and basophils. That would result in the release of mediators, including histamine, leukotrienes, cytokines, and others. And those mediators will be responsible for the development of the different signs or symptoms that you can expect to see in allergic rhinitis as well as asthma. So in terms of targets, again, target rhinuria, you can use anticholinergic agent, for example. You can relieve congestion using vasoconstrictors for the nose or beta agonists for the lungs for bronchospasm. You can go upstream and start targeting the receptor for histamine or for leukotrienes. You can reduce the releasability of mediators, reduce the number of allergic inflammatory cells using steroids, for example. You can work further upstream. There's something called omalizumab or anti-IgE that we use for patients with moderate to severe allergic asthma, but don't forget the allergens as well. So regarding patient care, those are the different approaches. You gotta talk about allergen avoidance because that can be relevant. So regarding allergens, you can have outdoor allergens that can come from trees, grasses, weeds, or molds. Molds can also be found indoors. For pets, cat and dog allergens can be notorious. You can have roaches as well as dust mites. The video here just shows the dust mites that you can find inside the pillows, inside the mattresses. They're microscopic. They feed on skin flakes, so in able to survive, you have to be around where they can find food. And that's skin flakes, so you find them inside the beddings, again, inside the mattress, as well as the pillows. It's going to be virtually impossible to get rid of them, so what you can do would be, try using some encasements. There are different approaches regarding allergen avoidance. Regarding dogs and cats, one misconception is that certain breeds are quote-unquote hypoallergenic, and what you need to remind your patients is the fact that there's no such thing. All dogs, all cats produce allergens. The allergens are proteins in their saliva, their skin, dander, and even their urine. One thing about cat allergens that make them more problematic compared to dog allergens is that they're sticky, for lack of a better word. And what your patients need to understand is that even after finding another place for their cat, if they choose to do that up to 6 months down the road, they can still have cat allergens because they stick on the wall carpeting, upholstery, even clothing. And that may explain why studies have shown that even in places where there are no cats, like schools or homes without cats, you can find significant levels of cat allergens. One question is, whether or not washing the cat can be helpful, and the answer is no, unless if you wash the cat every day, the cat may hate you, run away, and that would be the only way that washing the cat would work. Otherwise, it won't. So regarding allergen avoidance, is going to be part of the strategy, but I can tell you it's going to be difficult. So pharmacotherapy, as I pointed out earlier, will be playing a major role here. I already talked about the different options. You can group them into two. You have rescue medications that can be used as needed because they have a fast onset of action. For example, antihistamines would start working at least 90 minutes after ingestion, so you can use them as needed. In contrast, controlled medications such as intranasal steroids will take several days before they start working. And your patients need to know that, otherwise they may start using the intranasal steroid sprays and then give up on them after 1 or 2 days because they didn't notice any difference. It's going to take several days before they reach their maximum impact. This is a list of the different antihistamines available at least in the Philippines. One thing that I'm pointing out here is that you have old generation antihistamines such as chlorpheniramine or diphenhydramine. And these are very good antihistamines. The problem is that they cross the blood-brain barrier. So the brain has histamine receptors as well, and these can produce the side effect of sedation. In fact, some people take diphenhydramine to help them sleep. The newer generation antihistamines do not cross the blood-brain barrier, so they would have less of that side effect. You have bilastine, cetirizine, desloratadine, fexofenadine, levocetirizine, and loratadine. We have all of those antihistamines here in the U.S., but the only thing that we don't have here, but apparently is available in the Philippines now, is bilastine. One point that I'm going to make here is what you can observe here. Cetirizine and levocetirizine, they're related. You have loratadine and desloratadine, and what happens is that the pharmaceutical companies come up with these medications. For example, cetirizine was a blockbuster drug in the 1990s, and then once the patent runs out, they come up with something new. In this case, levocetirizine, but one criticism that I have here is that these are just derivatives or metabolites that are not necessarily superior to their preceding parent drug. So again, levocetirizine and cetirizine, they're comparable, and desloratadine, which is an offshoot of loratadine, they're also comparable. The challenge really is to come up with something that would be better than the preceding medications that were available. In terms of anti-leukotrienes, you have montelukast. For steroids, you have them listed here: beclomethasone, budesonide, fluticasone, and mometasone. So regarding pharmacotherapy for asthma, it's very similar to the treatment of rhinitis, and we're going to have a separate webinar regarding asthma. And I'm just going to point out here that parallel to the treatment of rhinitis, you have rescue medications that can provide an immediate but transient relief. In this case, the short-acting beta agonist or albuterol. And then you have control medications that have to be taken on a regular basis for maximum impact, and that would include the steroids. You also have steroids combined with long-acting beta agonists, and you also have anti-leukotrienes. Third strategy that we employ for rhinitis as well as asthma is immunotherapy, and this is just one slide that would demonstrate that it has long-term effects. This was published several years ago in the New England Journal of Medicine. They compared the effect of placebo versus immunotherapy. So in one subset of patients with allergies, they continued to have immunotherapy injections from 1989 up to the end of the study in 1995. And in another subgroup, they had immunotherapy that was discontinued in 1992. And as you can see here, among the volunteers who received placebo injections at the peak of the pollen season, they have a significant increase in their symptom scores. Those receiving immunotherapy, as expected, had a reduction in their symptoms. What is interesting is that those individuals who received allergen immunotherapy injections, but the injections were discontinued in 1992, up to 3 years later, they continued to have significant reduction in their symptoms. So these clearly demonstrated that allergen immunotherapy has long-term effects. So far, this is the only proven treatment that would have long-term benefits. So I've talked about the treatment of rhinitis and asthma. That would include allergen avoidance, pharmacotherapy, and immunotherapy. One question that I frequently encounter is this: what about alternative remedies? And this is something that just came out this week. You can see here, this is published in our local newspaper here, the Baltimore Sun, wherein they talked about the fact that seasonal allergies drive some individuals to alternative remedies. And for anybody who's thinking about alternative forms of treatment, and that's true not only here in the US, as you can see in this article published just a few days ago. This is definitely true as well as true also in the Philippines. So what I would advise really is to have an open mind but critical mind. So if you have form of treatment that would have some scientific basis or clinical proof of efficacy, then that's something that you can explore. Otherwise, I would be hesitant to advise that. This summarizes what we talked about. I talked about allergic rhinitis in relation to asthma, and I proposed and hopefully demonstrated data that this is actually one airway and one disease that we're encountering. And I talked about the prevalence of these conditions and the significant overlap between allergic rhinitis and asthma, and the similarities between these conditions regarding the pathophysiology. You have similar approaches. One take-home message again is the treatment of rhinitis can have beneficial effect on asthma. Thank you very much for the opportunity to do this webinar. If you have any questions, I'll be glad to answer them. If you have any questions down the road, feel free to shoot me an email. My email address is at the bottom of this slide. And right now, I'm open to questions. Thank you.
Thank you for that insightful and extensive discussion, Dr. Sanico. I'm sure that the audience really learned so much from the information you just shared. We would also like to thank our sponsors, Marine Philippines, GSK, Natram, and Denmark, and the Philippine Daily Inquirer as our media partner. Before we proceed with our question and answer portion, let's have one of our panelists give her reactions. I would like to introduce Dr. Rozan Caro, who is an associate professor and chief of the Research, Implementation, and Development Office of the UP College of Medicine. She's also an assistant chair for research of the Department of Otolaryngology of the University of the Philippines, Philippine General Hospital, and an active consultant at the section of Otolaryngology, Department of Surgery, Capital Medical Center. We will now call on Dr. Caro.
Good afternoon. Okay. Thank you, Alvin. That was a very comprehensive lecture on the relationship between allergic rhinitis and asthma, what we often refer to as the United Airways. Right? Yes. Okay, you can relate to that. Now, I really like that statement of the nose is a reflection of the lung. Okay? In fact, as an otorhinolaryngologist, when this concept of United Airways came out, it already became routine for me to auscultate my patients. Okay. So actually, when you talk the United Airways, there are three things that you should always remember. One is that if your patient has asthma, and like you pointed out, never forget the nose. Evaluate the nose. Second, if you have patients who have both allergic rhinitis and asthma, okay, you have to manage both conditions. And I think you've shown it in one of your slides, wherein there was a study that if you gave your inhaled and intranasal steroids, the patient's asthma improves significantly. Lastly, we have to employ all treatment options that will be directed both to the upper and the lower airways. Okay. So if we look at it, allergic rhinitis and asthma, as you pointed out, are both chronic conditions, inflammatory conditions, and in our setting in the Philippines, wherein we have not only the problems of pollution, okay, we are encountering actually highly prevalent cases. It's highly prevalent that we have now allergic rhinitis, but we also have what we call the mixed rhinitis, right? And I think it was pointed out by the American Academy that we have both allergic and non-allergic rhinitis happening in a patient in a group occurring about 40 to 87% of patients. So some patients come to us, their only complaint will be reaction, hyperreactivity with changes in temperature. But when we do further probing of the history, actually you'll be able to trace that there is actually an allergic component. And I'd like to share with you also, Alvin, that together with your classmate, Marisha Recto, the section of allergy of the Department of Pediatrics and Internal Medicine. I have to keep on adjusting this because it keeps on falling. Okay, I think this is better. Okay, okay. Together with the Department of Allergy, we have come up actually with a joint consensus on the diagnosis and management of allergic rhinitis. We're just awaiting the release. It's actually going to be published in Acta America first issue, so it's supposed to be out anytime. And the beauty of it is finally the otolaryngologists who are more clinically based and the allergies have come to an agreement as to how to manage allergic rhinitis. And I think both we did agree that we do it first, manage it based on the clinical history, and of course we have, as you pointed out, okay. As pointed out, the four cardinal symptoms: sneezing, rhinorrhea, sneezing, rhinorrhea, nasal obstruction, and pruritus. Okay. You have 2 out of the 4 for more than 1 hour on most days. We think allergic rhinitis. So clinically, we can manage the patient as such. Okay. Now, when you talked about oral antihistamines, you pointed out the rescue and the control medications. I think for us, when we first see our patients with allergic rhinitis, initially we have to give both our oral antihistamines and our intranasal steroids. We actually follow the area guidelines and classify our patients as such. So most of our patients have persistent, moderate to severe rhinitis. And we manage a patient, and if controlled, actually what happens is that we refer to the oral antihistamines as the rescue medications later on and continue the intranasal steroid. Okay. Now, there's also one thing about the United Airways, and I think you said something earlier that the nose is a reflection of the lung. And now when we look at the nose, we cannot actually separate it from the sinuses. So now they say what has evolved in terms of United Airways is allergic rhinitis, chronic rhinosinusitis, and asthma. Yeah. And I think if you think we talk about the prevalence also, we've encountered that in supposedly in patients with asthma, 37% approximately have chronic rhinosinusitis, and those with chronic rhinosinusitis, and we've actually distinguished those with nasal polyps and without nasal polyps. And they found out that those with nasal polyps have more eosinophilic etiology, and they found out that about 40% actually had asthma, and without nasal polyps, which is more neutrophilic, about 22% had asthma. So now I think this is one area that we have to consider. We have to be aware of the existence of chronic rhinosinusitis, and it has been shown that 20 to 75% of patients have coexistent allergic rhinitis and chronic rhinosinusitis. So gone are the days when we would look at chronic rhinosinusitis as actually an inadequately treated acute rhinosinusitis. Now it's more inflammatory than infectious. So if you look at, like you pointed out earlier, the anatomical changes, okay, the pathophysiology, there's also basement membrane thickening in the sinuses, and then also increase of eosinophils and leukotrienes. So they say now when you look at chronic rhinosinusitis, it's quite difficult because it's multifactorial. Fungus can come into the picture, reflux can come into the picture, of course, allergy, anatomic changes. So there's always what we refer to as the chronic rhinosinusitis triangle. So there's an interplay of what happens in the sinuses, the mucociliary dysfunction, the mucosal inflammation, and the local microbial pattern. So actually, when we encounter patients, which is what I want to share, we come with patients who seem to not be responding to our allergic rhinitis management, okay? And if you look further, and that's the role of, I think, the otolaryngologist, when we look at the nasopharynx, we see a lot of secretions there, okay? So when we look at that, we start considering that this patient might actually have CRS. So when we diagnose CRS now, we always consider that obstruction is a consideration. Basic patients will come to us. Rhinorrhea, it's colored, thick. But when you look at it, not all patients have colored rhinorrhea. They have very thick rhinorrhea that's stuck in the nasopharynx. Okay? Smell disturbances is another one important symptom that we have to ask our patients now. Okay? In fact, facial fullness is not that common with chronic rhinosinusitis. So, like what I said, we have to take this into consideration. Of course, if you look at the guidelines, you have to have 2 out of the 4. One should be either discharge obstruction, but you have to document the inflammation. And one way of doing that is to do your endoscopy, nasal endoscopy, to see if it is with or without nasal polyps, and or your CT scan. So in terms of management then, so if you consider all 3, basic would still be the oral or the topical corticosteroids. Leukotrienes, since they're also seen there's also now a role for your Montelukast, which is available here. Okay. Of course, there's also the role of long-term macrolide antibiotic therapy, but that might be a separate webinar. Okay, so with that, I hope we will take that into consideration when we see patients who seem not to be responding to our allergic rhinitis management. Think CRS as a concomitant condition. Okay, thank you.
Thank you very much for that engaging discussion, Dr. Caro. To summarize briefly, allergic rhinitis and asthma are very closely interrelated. They both affect the united airways. So management should be comprehensive and complementary to ensure better patient well-being. I think we need to drive home the point that this allergic rhinitis is primarily inflammatory rather than infectious. Because I think a big problem here, especially in the Philippines, is the tendency to give antibiotics for every time a patient presents with nasal discharge. With this webinar, I believe we can drive home the point that probably we should be dealing with inflammation rather than infection. The other point that I would like to emphasize is Dr. Sanico mentioned something about alternative medications for allergic rhinitis and asthma. We know a lot of patients are now seeking non-medical management, and it's imperative upon us physicians to ensure that our patients get good information from us so that they don't get to go to shopping with other medical practitioners. I think we have time for some questions. One question is, many are fearful that the use of intranasal inhaled corticosteroids will lead to steroid side effects. Is this a well-founded fear? And how do you deal with this, especially in patients with persistent allergies who are already on long-term steroids? Dr. Sani?
Yes, thank you very much for the questions. I really want to drive home the point made earlier about chronic rhinosinusitis, and this is an extension of the notion that this is essentially one airway in one disease, and the sinuses, no question about it, are part of the pathophysiology. In fact, I didn't cite I didn't show slides of the studies that demonstrated that in as much as treatment of rhinitis can improve asthma outcomes, a number of studies have also demonstrated that treatment of sinusitis among those with concomitant asthma that is fully controlled, as well as sinusitis, can lead to better outcomes related to their lower airway. So again, treatment of sinusitis can also improve asthma outcomes. Regarding the question about steroids, it's a frequent question, especially here. You have athletes being accused of using steroids. One thing that you need to educate your patients about is the fact that those are anabolic steroids. So you just have to tell them, these will not bulk up your body, whether or not you want to see that. And one key point to understand, educate your patients about, is the fact that the bioavailability of the newer generation steroids, whether or not they are intranasal steroid sprays or inhaled corticosteroids, the bioavailability is low, meaning you don't really absorb that. You can have local side effects. For example, with intranasal steroid sprays, you have to instruct your patients regarding the proper use of sprays to avoid complications such as septal mucosal erosion or bleeding. For those using inhaled steroids for their asthma, they have to, for example, really rinse their mouth after each time that they use it to avoid oral thrush. So you can have local side effects, but really the systemic side effects are not to be expected because of low bioavailability.
Thank you for that response. And for our next question, is the link between the upper and lower airways only seen with allergic rhinitis? What about if the patient has other forms of rhinitis, like viral or vasomotor rhinitis? I think Dr. Recaro can also answer that. Alvin?
Okay. I think, so I've focused on allergic rhinitis, that was the assigned topic, but the majority of the observations regarding the pathophysiology as well as inflammation would be similar, although they're not identical. For example, for those dealing with non-allergic infectious rhinitis or non-allergic or intrinsic asthma, other factors can play a role, resulting in increased neutrophils, for example, instead of eosinophils. But otherwise, in terms of the clinical symptoms, there's an overlap. One key point to understand as well is that those who have allergic rhinitis would have a higher probability of developing symptoms upon exposure to irritants. For example, as I pointed out earlier, those who have allergic inflammation, when they're exposed to pollution, whether or not you're talking about local pollution like tobacco or cigarette smoke, or pollution from exhaust fumes, you're going to have increased development of symptoms. Uh, Not because you're allergic to those factors, those are not allergens, because some patients would tell me and say, you know what, I'm highly allergic to cigarette smoke, meaning it triggers symptoms. And you just have to inform them that it's not an allergen, it's an irritant, but it can certainly trigger the same set of symptoms. And if you have inflammation going on, you're going to be more responsive to those non-specific irritants.
Okay. There's a coronary question. If patients, from one of our audience, if patients have epistaxis, can they still use intranasal steroids? And what is the alternative?
So epistaxis or nasal bleeding is something that can be avoided if they use the proper technique. The key point really is to instruct them to avoid pointing towards the septum. So they have to point nasal sprays either straight up or away from the septum. But if they have epistaxis or nasal bleeding, they have to hold off on not just intranasal steroid sprays, but any form of nasal sprays for that matter until the mucosa heals. If it's recurrent, then you have to, number one, find out why, whether or not it's just from septal mucosal erosion or for something else, and look for other forms of treatment, and that would be the oral medications.
Okay, thank you.
Okay, I
Yes,
say something about the epistaxis and intranasal steroids. Actually, we've been prescribing intranasal steroids to a lot of majority of our allergic rhinitis patients. And epistaxis has not been really a significant problem. Of course, as pointed out by Alvin, proper instruction is very important. But what we've noticed, though, is that there are patients, even if you direct it laterally, the bleeding might not actually be coming from the septum, and you see bleeding points in the turbinate. Because I think that's the difference between the American and the Asian nose. It's shorter. And when the turbinates are hypertrophied and they insert the nozzle, it actually irritates the inferior turbinates. Do we really stop the use of the intranasal steroids? Like what I said, we still have to encounter somebody with massive epistaxis, and based on studies, it's not really that significant a problem. What we have known, what I would like to share though, is that when a patient has epistaxis, the first thing we want to find out is where it's coming from. Okay, so like what is pointed out, anterior part of the septum, we actually give our oxymetazoline, our topical decongestant, to constrict the vessels. Okay, so that can be an approach. Holding the steroids might be an option if it's really massive, but if it's very mild, we can just give the topical decongestant followed by the intranasal steroid. One thing, and pointed out earlier, as the alternative would be the role of the neti pot and all the nasal washes. I think as an otolaryngologist, I can say that they do work, not necessarily the neti pot, but any form of nasal washing. Saline irrigations are very, very good for rhinitis, for sinusitis. So I think that should also be a consideration in the management of patients.
Okay. We have several questions we're actually interrelated. Yes, Dr. Sanico?
Yes, if I may want to add to that. That's one of the last couple of slides that I showed regarding use of alternative remedies, because that's certainly commonly practiced, not just in the Philippines, but even here in the U.S. And, as I indicated earlier, and I'm going to emphasize, have an open mind, but critical mind. We have to have an open mind because that's how discoveries are made. Remember back in the during college of medicine days, we did a number of studies looking at different herbal preparations, And in the end, one challenge is the fact that a lot of the herbal preparations is a mixture of not just one or two different ingredients, but up to several dozen. So it's going to be very hard, if not impossible, to subject them to clinical trials. One comment that I sometimes hear is that patients would say, yeah, you know what, I'm not sure if this herbal preparation is helpful, but it's not going to be harmful anyway. So it may not be helpful, but it's not going to be harmful. But the problem is that may not necessarily be true. There are certain herbal preparations that have ephedra, for example, which can elevate blood pressure. So the take-home message is that we have to be aware that this is something that is being done, whether patients admit it or not. We're going to look into alternative forms of treatment. It's really up to us to explain to them, the potential pros and cons. There was mention of the netipat or the saline irrigation. In the article that I showed earlier, I mentioned that there are actually studies demonstrating the usefulness of saline nasal irrigation. So I mentioned that that's something that is not a form of medication, but can certainly provide benefit. So that's one example of keeping an open mind that that would allow us to consider forms of treatment other than medications that can have potential benefit.
Thank you, Dr. Sanico. And one question which is repeated here in our chat box is about intranasal steroids. How long can you use intranasal steroids continuously before curing nasal atrophy, in days or weeks or months? And if a patient is on inhaled and intranasal steroids and you've already controlled the symptoms, which one would you taper off first? Or can you taper them both at the same time?
Yes, okay. That's a very good question. One point that I always emphasize among patients with asthma that I have mentioned yet is this. I always tell them that the goal is and always will be maximal control with less medications. Maximal control with less medications. And you can achieve that goal if and only when you're able to identify anything and everything that contributes to the problem. That's why, checking whether or not allergen sensitivity is playing a role is part of the approach. Now, regarding the safety of long-term use of intranasal steroids, that actually was addressed by a study published several years ago that looked at the effects of intranasal fluticasone on the histology. So they did biopsies before and then nasal tissue biopsy before and then 1 year after daily use of intranasal fluticasone. And what they showed was that there was no atrophy. Atrophy can be seen in the skin. If you use topical steroids on a long-term basis, you can see some degree of skin atrophy, but that actually does not happen in the nasal mucosa. What you can expect to see is the reduction in cells, particularly the inflammatory cells associated with allergic inflammation, in particular mast cells. So a 1 year use of nasal steroids has been demonstrated by that study to reduce the number of mast cells, but there was nothing equivalent to atrophy that you can see if you do the same thing, apply topical steroids on the skin for a year, for example, and you can see skin atrophy. That doesn't happen in the nose. So again, I just want to emphasize regarding the question about reduction of steroids, you always want to do that. So if you are using inhaled steroids for asthma, for example, and as you may be aware, almost all of the inhaled corticosteroids for asthma come in different strengths, either 2 or 3 different strengths. So you would want to always try to attempt to step down. So step down if you could, step up if you have to regarding treatment with inhaled steroids among patients with asthma. So regarding the question about concomitant use of intranasal as well as inhaled corticosteroid, that's a good question, but the effect, is mostly topical, and just apply that any strategy that would result in reduction in inhaled steroids if you could. So you may want to start with that if you want to reduce the use of steroids.
Yeah, I think in that particular study, if I remember right, Alvin, they actually demonstrated the re-epithelialization of the nasal mucosa. So that's why the intranasal steroids have a significant role in the management of allergic rhinitis. As to the duration, I think intranasal steroids, and you're right, pointing it out, the new generation have very, very negligible systemic bioavailability. So they're safe for long-term use. So the studies on this would actually range from 1 to 2 years in adults, and in the pediatric patients for 1 year. There are studies on this. And the dictum has always been as the lowest effective dose. So among otolaryngologists, we start off with 1 month use of the intranasal steroid, and then continue, but may actually lower the dose until we achieve good control. Unlike asthma, wherein they say you have to give it for 3 months to achieve control, there are no such studies for allergic rhinitis, but we've always followed at least 2 months of continuous use.
Thank you. We have time for one more question. So, how will vitamin D supplementation affect patients with allergic rhinitis? And 2, what is the effect of prolonged usage of the decongestants, nasal decongestants, for patients with, would you recommend it, and for how long?
For
decongestants for allergic rhinitis.
Okay, for
Yes,
allergic rhinitis and use of intranasal decongestants like oxymetazoline, one problem there is that if you use it on a chronic basis, you can have rebound congestion, and your patients need to be aware of that. They may be tempted. This is available over the counter now. They may use it and then realize that, wow, this gives them immediate relief, but the effect is immediate but temporary, and it's okay to use for maybe 3, 4, 5 days, but not on a long-term basis to avoid rebound congestion. So what happens in that phenomenon is that every time they try to stop, they have worsening, so they keep on using it. That's why some people call it quote-unquote addicting. It's not really addicting like opiates, but that's something to avoid. Regarding the use of, going back to the question about when and for how long you should use steroids, either for the nose or for the lungs, one basis for the decision making will be whether or not they have sensitivity to seasonal versus year-round air allergens. For example, if you have somebody who is allergic only to tree or grass pollen, you can advise him to start using the control medications probably about a week before the start of the pollen season, which over the past several years we've observed to start happening earlier and earlier. So things are changing in the environment. But advise him to use it on a regular basis during the pertinent season and then stop it afterwards. For those who have sensitivity to year-round air allergens and they have year-round symptoms, then you may end up having to tell them that they got to stick with it, if you cannot apply the other approaches, and that will be avoidance as well as immunotherapy.
How about vitamin D in vitamin D deficient children with rhinitis?
There's really not a whole lot of data regarding vitamin D and rhinitis, so I have nothing to advise regarding that specifically.
Okay.
Okay, first the role of oxymetazoline and whether it really causes rebound rhinitis. Yes, we always advise our patients. But actually, we use oxymetazoline to prime the nose before we give our intranasal steroids. because a number of patients actually go straight to the intranasal steroids, and since the turbinates are hypertrophied, they do not hit the area where it should hit, which is the area of the lateral nasal wall. So we use it to prime the nose, and when the steroid actually starts to work, there will be no need for the oxymetazoline because the obstruction has been relieved. Now, the role of vitamin D, actually it has something to do with improving the immune system. In fact, in the 2015 International Consensus on the Diagnosis and Management of Chronic Rhinosinusitis, there's not enough evidence for, in terms of the role of vitamin D in the management of CR.
This has been a very instructive session. I think everybody will agree. After this session, an email will be sent to you containing a survey link. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Special thanks to Airway in the Philippines, GSK, Dr. Farm in Denmark for sponsoring today's webinar. Thank you for joining us. We hope to see you again in our upcoming webinar on May 25, next Monday, 12 o'clock again in Manila time, with speaker Dr. Glenn Benitez to be speaking about cervical cancer. Please invite your colleagues to join this in our continuing monthly CME webinar session. All webinar schedules and resources will be posted at www.upm.edu/upmedwebinars. In behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management Service, the National Telehealth Center, UP College of Medicine, Postgraduate Institute of Medicine, and the Medical Informatics Unit, DST, ASTI, and Ms. Cherise Arhalo, our host. We'd also like to thank the Philippine Daily Inquirer for your support as our media partner. This is Dr. Esther Sagel, together with Dr. Alvin Sanico, Dr. Rozan Paro, and the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again next Monday, May 25, and have a great week ahead. Thank you.
Thank you.